Dr. Gaddis over here. I'm Mo Omar. Nice to meet you all. Today's an extremely special day for us, not only because of the fantastic speaker who we'll introduce in just a minute, but it's also the first presentation that we're having in our new venue. As you can see, we're all in. Sorry.
Mo, I think you got muted.
Sorry, I did get muted. As I was saying, so this is the theater space where we'll host most of our presentations moving forward. We're really excited to host our first one today with our esteemed speaker, Dr. Markle, who will introduce better in just a minute. We have a gallery behind us all right now where we'll be displaying our 3D models. And as we continue to grow that archive, you'll be able to interact with more of them, not only on Thursday nights, but at any time that you wish. So moving forward with today, Dr. Gaddis.
Thank you, Mo. Appreciate that. So I'm pretty excited about today's event because I'm going to introduce my good friend, Dr. Jason Markle, who is based out of Denver, Colorado. He's an absolute juggernaut in the orthobiologics space. So let me just tell you a little bit about him. So Dr. Markle is a board-certified physiatrist and fellowship-trained in interventional orthopedics. He has a vast experience with all biologics, from PRP to culture-expanded mesenchymal stromal cell treatments for musculoskeletal conditions. And he's a partner at the Centeno-Schultz Clinic, which I'm excited to be joining them at the end of the year, where his practice is 100% focused on orthobiologics for sports and spine disorders. He has multiple clinical studies and publications on multiple orthobiologics, PRP, BMC, cultured MSCs for disc injuries, lumbar radiculopathy, ACL tears, rotator cuff tears, and all sorts of other arthritic conditions, including the shoulder and the knee. So everybody put your virtual hands together and let's give it up for Dr. Jason Markle. I will say before we get started, just so that you know, those of you in the audience, if you actually point and click on the presentation, it'll advance the slides. So we just ask that you not click on the slides so that Dr. Markle can advance at his own pace. All right, the stage is yours, Dr. Markle.
All right, great. Well, thanks for everybody. Thanks for having me. First of all, thank you, Dr. Gaddis and Dr. Omar, for having me. This is my first time out here, so if I screw up a little bit, just let me work my way through it. But as Dr. Gaddis said, I am a physiatrist, PM&R trained, board certified, and did an Interventional Orthopedic Fellowship, which is 100% dedicated to orthobiologics, working in sports and spine injuries at the Centeno-Schultz Clinic. Here's some of my disclosures. I am a co-owner of Centeno-Schultz Clinic, as well as I sit on the board of a nonprofit organization called Interventional Orthobiologics Foundation. And that's a nonprofit organization that helps foundational training and really training physicians, board certified, even younger physicians, on really how to do some of these injections. Very much a standardized curriculum, as well as a Regenic provider. In our clinic, Centeno-Schultz Clinic is actually the headquarters of a worldwide physician network called Regenics. So we train all these physicians and mentor a lot of these doctors as they get started in the world of biologics. So before we even start on biologics, let's talk about how we look at the spine. Traditionally, interventional orthopedics or interventional pain physicians have a different outlook of how they organize and think about the spine. Really, it's called the hold on one second. So looking at the way pain physicians really look at spine, it's more or less a pain generator model, meaning find where the pain is coming and then we blast it with steroids, radiofrequency ablation, trying to get rid of the pain. Well, with the world of biologics, that sort of thought process has changed in the way we look at the spine. So the first thing to talk about is really the functional spine unit. This is was popularized in probably the 1980s, 1990s by a couple of spine surgeons. They broke down the spine into the single most functional unit of the spine, which is essentially two vertebrae, the disc between them, and the facet joints that connect the two, as well as the ligaments that connect those segments. And the thought process is that any two of these columns, if they get damaged, the spine is unstable. So that's how they categorize patients and basically who they fuse and who they didn't fuse. From a biologics world, we look at this model and identify, it's like, okay, if something gets damaged, for example, degenerative disc disease, we have loss of disc height, whiplash, we have damage to the facet capsules and ligaments. They all affect each other. And the articulation is brought about the disc as well as the two facets. And one thing affects all the others. So when we're treating the spine from a biologic standpoint, it's something we always don't just treat a single structure, we treat the full functional model. So if I'm treating a disc, I'm also likely treating the facets that are overloaded, the ligaments around there, as well as an atrophy of the multifidus that causes some weakness and persistent instability. So it's not just one pain generator model where it's like, okay, the disc is the problem, let's treat that. It's more of a functional spine thought process where, okay, we're really treating the entire functional unit from the ligaments, from the joints to the nerves epidurally, as well as the disc. So even though I'm talking about the disc injuries and indications today, I want you to think like, okay, even if we do that, let's make sure we're treating the full functional spine. And that really will maximize your outcomes from a biologic standpoint, as well as long-term wise, it'll help decrease the patient's pain, improve the function, and keep them out of your office more. Hold on one second, this thing in front of me. There we go. All right. So, and if you notice, the foundation of that model is the disc. The disc spans two out of those three units or columns. So any damage to the disc is inherently an unstable segment. And that's one of the reasons why treating the disc is really, really critical. So let's talk about some of the anatomy of the disc. So the disc is really made up of two parts. You have your nucleus fibrosus and the annulus propulsus. Annulus fibrosus and nucleus propulsus. So two parts of the disc, one of the cushion, one the structural elements of it, the annulus. And they really support and allow flexibility for the disc. And the nutrition is all sort of come from the end plates above and below. So everything is diffused through the end plates into the disc. And that's we'll find that one of the reasons what makes this disc unique environment. So the progression of degenerative disc disease and how we can prevent it, it's sort of, once you get a disc damage, it sort of progresses where you lose a little bit of disc height, and all of a sudden we alter the biomechanics, it becomes an unstable segment. The progression is it starts overloading the facet joints, starts irritating the exiting nerve roots, and eventually creates severe degeneration, and then symptoms start developing. So it's why the disc is so critical. Maybe early intervention, if you are treating patients with this, will probably be somewhat beneficial. So the biggest question a lot of people ask me is, when do I go into this? When do I stay out of the disc? Which is a critical, important, and it's a good conversation to have with all of your patients. Now, intradiscal or extradiscal. Now, if we look at what are the indications of really treated disc, all the symptoms when talking to a patient, one of the biggest symptoms you'll ask and they'll probably tell you is like, man, I can't sit for very long. I sit for 5-10 minutes and my back starts aching, or I sit for a little bit longer, I start getting radicular symptoms such as a chemical radiculitis or chemical radiculopathy. So we find that sitting tolerance is a big discogenic pain generator. And if we look at some of the research and literature, looking at their MRI, even after they've sort of discussed some of the history, we'll find that the HIZ, or high intensity zone on MRI findings in the disc, is also highly correlative to that sitting intolerance and discogenic pain. So sitting intolerance is a big indicator, whether the disc is degenerative or just an annular tear in a younger population. And historically, disc injuries and discogenic pain are your younger populations, anywhere from 30s to early 20s to 40s are probably the big window, but I've treated and seen patients that have discogenic pain much older than that, as well as much younger than that. So disc injuries come in multiple forms. So if we look at just MRI findings, this far left here, you see the nice big annular tear in the bottom inferior recess of the disc, posterior disc, but you can also get disc extrusions or disc herniations. By definition, a disc is a tear of the annulus, allowing that disc or nucleus purposus to extrude or herniate, as well as just general degenerated disc. We look at the far right. It's just an angry degenerated disc, but this is a patient who is probably in his early 40s, very much discogenic pain, father of two. It's actually one of my co-residents I did fellowship with before I treated him earlier this year. And then, as we also mentioned, the disc is a huge stabilizing segment of the spine. So pathologies of instability, so if we look at the top portion of it, we see that anterior lethesis base of the slippage. So the slippage, the disc provides 2/3 of the stability of the overall spine. So when we're thinking about treating an unstable segment like lethesis with someone without myelopathy, so if someone has weakness, progressive weakness, that's when surgical indications really don't even try an injection. You want more of a surgical option, but if this is just more of a pain, whether it be radicular pain, sitting pain, functional pain, whether it be axial or radicular, and we think about treating the disc for the stability overall, that's would sort of qualify as an indication for treating a disc. So the holy grail of degenerative disc disease or orthobiologics for the spine, you get a degenerated disc or a painful disc, which would be this guy, and we do an intervention such as an intradiscal biologics, and then lo and behold, we can reverse that all the way into a nice, beautiful, perfect disc with progressive improvement of disc height, annulus, as well as the nucleus. The problem with that is it works really well in animal models. This is a study on culture expanded treatments where we can see in this right picture, the stem cell group or the culture expanded MSC group, you see a nice, beautiful, regenerated intervertebral disc. Now, quadrupeds are far different animals than bipeds such as humans. So in translational medicine, this really doesn't happen, unfortunately. We've tried, and actually this is one of the things that got Dr. Centeno starting doing orthobiologic injections and researching it back in the early 2000s, and he was actually the first person in the world to inject stem cells or culture expanded stem cells into intervertebral discs, trying to replicate what we've seen in animal models. Doesn't really happen, but we found a lot of other interesting things over the time. So one of the things that the biggest dilemma of like how we can get the disc to regenerate or basically reinnervate and things like that is it's a low oxygen environment. So it's a low nutrient environment, low oxygen environment. So you're putting all these cells or whatever you're injecting into basically a desert. So that desert does not really preclude and really help the proliferation of cells to really cause any regenerative healing capabilities, as well as it's a very acidic environment. So it's a very toxic environment. So it's basically taking all these cells and putting them in the Sahara Desert with no water and expecting them to actually survive is one of the biggest limiters in intervertebral disc injuries and why it's so difficult to treat. Because we've published on other treatments such as bone marrow constrictor, PRP, for radiculopathies, for ACL tears, rotator cuff tears, and those are relatively, in the right situation, relatively easy to get those to essentially heal to some degree and improve the patient's function, but the disc continues to be a problem because of these reasons. So knowing that, and then it's like, okay, so what am I going to put in the disc? Always becomes a point of contention. Now, there's a lot of, if you look at the market of orthobiologics, there's a lot of stuff out there that's actually some good, some bad. But if we look at these first two columns over here, it's basically when it mess with too much of the orthobiologics from the birth tissues, exosomes, because one, there's very little data or research out there that actually is showing one, the safety as well as efficacy of these. So for any orthopedic condition, not only the disc, but any other tendon, ligament, nerve, what have you, there's really no data or research is saying any of these tissues are actually, one, even have stem cells in it, even though they're marketed as a stem cell injection. There's been multiple studies at this point from our clinic and Dr. Nevin Steinmetz, who's also in the audience today, as well as Brown University and UC Davis, looking at some of these amniotic products, and there's no living stem cells. There are cofactors and growth factors in there, but really there's no living stem cells. So anybody, it's sort of false advertising that's injecting these expecting or claiming them to actually have stem cells in them, as well as no research. So really it leaves us what we would call autologous products. So cells or products, tissue from you going back into you, and that becomes platelet-rich plasma, different cytokines like A2M or platelet lysate. Stem cells, we were talking about microfragment adipose tissue or bone marrow conjugate. And really from the data standpoint, we'll go over really bone marrow conjugate, MFAT or microfragment adipose tissue. One, it's still from a legal standpoint sort of iffy, and two, research-wise, there's not a ton out there. There's a processing of adipose called SVF or stromal vascular fraction. There's only really one study out there published. And also the legal sort of conundrum, which if anybody follows the news, this recently became somewhat legal from FDA standpoint, but that's only from a court case and that likely to be appealed here shortly. All right. So looking at these two, of the two, historically, people always say stem cells works best for everything. But the disc is one indication that I would probably say, as I'll go over, PRP probably outshines what we know right now of any bone marrow conjugate in the disc. The only offshoot of that is culture expanded MSCs. Now, we also have a clinic in Grand Cayman. I've been working with culture expanded stem cells for the last 7-8 years, and I can tell you quite handedly, that works really well, and we've published on it, such as disc herniations, and with excellent results with culture expand, as well as a good safety profile. So that's probably trumps everything, but that's not allowed in the U.S. under current regulations. But in the future, that could change. But right now, I'm going to say PRP, in my practice and in my indications, I would say PRP probably trumps all stem cell treatments or bone marrow conjugate injections. And if we look at the evidence in animal models, you would expect everything you would want to happen with platelets or growth factors or platelet-rich plasma into a disc sort of happens. You get proliferation in extracellular matrix proliferation. So this is all the building blocks of the disc, whether it be the nucleus or the annulus. And if in degenerated animals, it reduces degeneration of the nucleus purposus, as well as the cell death. So it reduces the nucleus purposus apoptosis. So it keeps the cells alive longer, helping it to maintain the environment of the disc. And it reduces mechanical stress that induce apoptosis of nucleus purposus. And that just means, okay, if there's damage to the disc, whether unfortunately this is a stab model, which doesn't really happen in real life, but it helps preserve and maintain those cells in the disc is exactly what you would want. And again, it reduces degeneration in the stab model. So everything you would want, it helps the disc heal, it helps the cells in the disc to maintain that environment and maintain the integrity. Maybe.
Again, if I could just ask those in the audience not to click on the slides so that Dr. Markle can advance at his own pace.
All right, we're getting there. All right, and next we go to actual human models. So that was all in the animal studies, but like I said earlier, translational medicine, does it really work in humans? All right. Yeah, Mo, I'm not sure what's going on. I'm trying to. Just bear with us for just a minute.
Clicking on the slides. See.
All right, here we go. So yeah, so now let's look at some animal, or go from the animal models to actual human models. We actually have level 1 studies, randomized controlled trial. Dr. Lutz at the HSS was kind enough to do several studies and looking at, does PRP, double randomized blinded control study, work? And overall 50 to 70% of those patients did really well with a very low with no really adverse events and good safety profile. And then they continued to follow those patients off for a very long time, 5 to 9 years. Again, they maintain that progression and improvement over that span. So we have some decent long-term studies that follow those patients using PRP. And then more importantly, we've done dosing studies. So Dr. Lutz luckily did dosing studies on high concentration of platelets or low concentration of platelets, and he's finding like, okay, so your dose really affects your outcome. So if we can increase that dose to 14, 20 times concentration by comparison to your baseline, we can get superior results comparison to a lower concentration such as 5 to 10 times concentrated. So which is important because when you're evaluating, if you're younger physicians looking at different kits to get, it's something you really pay attention to is like, what's my ability to concentrate the platelets out of these kits? I work in an environment that has a flexible lab platform, so we have a full lab that can tailor make whatever I want. So luckily, I have the ability to really concentrate as high as possible, as well as formulations we'll get into to really maximize our patient outcomes. So let's talk about actual patients here. So here's that degenerative disc here. We injected him within 3 months, got a new MRI. We can see really angry annulus. Right here is an annular tear post-anteriorly, some bulging and posteriorly, and he was getting some chemical radiculopathy, chemical symptoms with sitting intolerance, so we did an intradiscal injection, and within 3 months, he was 100% asymptomatic, and at this point, he's maintained this over the last 2 years. He's done really well. So this is what we would expect from an intradiscal injection. We improve the nucleus purposus, we improve the annulus fibrosis, but we do not gain any disc height. We cannot regenerate this disc, the lower disc, the L5S1, to the L45 disc. So it's what we would expect from a disc injection, that long-term wise, okay, we're seeing some actual structural change in those 2 different cell types, but we're not reinventing the wheel. We're not turning back the hands of time. We're not creating a 20-year-old disc in a 40-year-old guy. So next we'll look at a big disc herniation. So here's I think she was probably like 22, 25, somewhere in that range. CrossFit athlete, herniated disc after competition. This has been that way for about 2 years. At the time I treated, I got a new MRI just to make sure the disc is still pretty similar. And we went ahead and decided to go to an intradiscal injection. And we can see that large disc herniation, typically it measured right around 1.2 centimeters. It came now, it's more of a measures around 5 to 6 millimeters. So we're able to strengthen the annulus and it regresses the extrusion, and symptoms again continued to improve. This was from a single injection, and she's probably about 80-90%, and then re-aggravated her disc and dropped back to more like 70%, and has maintained this function. Even though the disc isn't perfect, symptomatically she's able to lift, continue fitness, and has really continued her day-to-day life without any sitting intolerance improved, radicular symptoms improved. And now the instability patient. So this is a patient who's multi-year history of axial back pain, car accidents, traumas with 3-level disc injuries. We can see a nice bright annular tear, the grade 1 anterior lethesis, as well as the L5S1 degeneration with annular tearing. But they all have decently preserved disc height. And this patient has instability as well as sitting intolerance with radiculopathy and radiculitis. So we went and actually injected all 3 of these discs. And here's her injection. And she, within probably 2 to 3 months, got back to high-level activity. She's a big outdoor enthusiast. She's hiking 14ers with intermittent symptoms. Every once in a while, she'll get a little bit of numbness and tingling down her leg, but for the most part, she's far functional, and she's able to play with her children and continue living the beautiful Colorado outdoor lifestyle. And then here's another one, just an angry degenerative disc. We can see a nice annular tear in this posterior annulus, also with modic changes, with end plate edema, and usually we don't inject degenerative discs. So a lot of people have degenerated discs. Doesn't mean everybody that has a disc, you should inject it. Only when certain criteria are sort of met, that sitting intolerance, with axial back pain is the biggest indicator, and this person had that. So I counseled them, like, okay, we can stay outside the disc or we can go in the disc. So luckily, we went in the disc, and within literally 6 weeks, he was close to 80-90% improved, and he continues to improve. I followed up with him probably about 2 weeks ago, and he continues. He actually went on a big kayaking trip a few weeks ago. Didn't have a single issue, jacked up his shoulder, but that's another issue. So awesome. You get your patients better, you'll get repeat customers. And then cervical spine. Now myself and Dr. Pitts created a technique utilizing ultrasound and live fluoroscopic guidance to really inject cervical spine discs. I've actually had 2 of my own cervical discs injected. And we've seen excellent results. We're pending publication on a large case series here. But that you can also inject cervical spine discs with excellent results. And we've seen an excellent safety profile as well as good results long-term wise. Basically, our goal is if someone's a disc replacement, fusion candidate, discectomy candidate, that's usually when we're like considering is like, okay, should we go intradiscal? And the vast majority of the time we've done really well and patients have continued to improve. Now this is a great case because not always, we don't always need to inject the disc to get some improvement of the disc. So this is a case where a 35-year-old patient came to me with sitting intolerance and actually a lot of chemical radicular symptoms. And most of her symptoms were the chemical radiculopathy or chemical radiculitis. So the annular tear in this posterior annulus was likely leaking into the epidural space, aggravating the exiting nerve roots. And we decided to do something a little bit.
What's going on here?
Oh, did you hear that? But this is a case where we stayed outside the disc, and all we did was utilize that functional spine model where we did epidurals, facets, ligaments, multifidus, and a few months later, her radicular symptoms were completely gone. And if we got a new MRI, and lo and behold, that large annular tear is actually healed up. She still has a small little disc protrusion, but asymptomatic and very little downtime, and we were able to get excellent results staying outside the disc. This is why having that conversation, discussing patients, sometimes doing the safer injection was probably the most prudent to really do initially, and then long-term wise, if they fail a less invasive treatment, maybe progress to an intradiscal. So let's talk about bone marrow. Now this is a point of contention with myself because there's a lot of publications in the world of bone marrow conjugate culture expanded treatment, and people always sort of misrepresentation, like this study that did a systemic review of intradiscal bone marrow concentrate. Now, the problem with this study, it included one of my own publications on culture expanded treatment. Now, culture expanded treatment is a vastly different injectate than a bone marrow concentrate. So it should not be grouped with bone marrow concentrate in comparison to culture expanded treatment. So these are isolated mesenchymal cells that are prepared in your own tissue medium, such as your own PRP, and then grown out to a higher number, purified, and utilize PRP as a carrier. And that's what we put in the disc. And we were shown excellent results long-term wise with pain and function, but also disc herniations and seeing reabsorption with that. So the actual data for bone marrow concentrate is actually far less, even though the reviewers and Ortho-Biologics is such a newer field. They don't really, some of the reviewers as well as even some of the people publishing this data don't know the difference and don't understand some of the details when a paper says bone marrow concentrate, but if you read the methods and material, you'll realize that they actually culture expanded and isolated stem cells, and that's what they were using versus bone marrow concentrate, which is an aspiration of your bone marrow. You concentrate it in the bedside centrifuge or in a lab, and that's what you injectate. So it's far different and something you need to critically evaluate all literature before you really use that data in your clinical practice, making clinical decisions. Because if we look at bone marrow concentrate, there's really 2 prospected level 3, level 4 studies that exist. This is a Bettine study that came out in 2015. 26 patients, so not a huge N. And almost half of those guys had less than 50% responded. Several patients did end up getting surgery, but for the most part, most of those patients, over half of those patients did get significantly better. And he was able to actually correlate that with your total nucleated cells. So he was set who had fewer, the more MSCs or low CFUs. I'm sorry, he actually did CFU counts. So the lower CFUs were actually attributed to lower outcomes. Looking at the dosing and how important that is, which was a good baseline study showing good safety and efficacy. But again, it's only a level 3, level 4 study comparison to PRP at this point that have multiple level 1 studies. And next we have another one came out in 2021 looking at a degenerative disc disease, and they were just actually doing more of a functional spine unit, injecting facets, discs, epidural, ligaments, and they were actually shown a good reduction of overall opioid usage. So that was good, as well as good safety profile. So these are really the two studies we have to hang our hats on for bone marrow contrite. So not a lot of studies have been done. And next, the risks of doing orthobiologics. Now, the risks, historically, we look at the risk back in 2006, a just discogram paper was published showing, okay, out of 12,000 discograms done from an interventional pain physician, what's the risk of discitis, which is the biggest thing you need to counsel your patients prior to these injections. And looking at just discograms, discitis in general, 0.0016% of them ended up with discitis. Per level, that goes down to 0.0056%. So it's very low risk for doing the injection. The problem is when we use biologics, we're seeing a little bit more increased incidence of discitis comparison to just doing an own discogram, which is important because there's a normal bacteria or microbiome in your disc, and both PRP and bone marrow contrite are antibacterial, so they can actually change the microbiome in your disc. And just like if you give someone antibiotics for a GI infection, you can give them C. diff for overgrowth of one of those bacteria. One of the biggest bacteria in there is going to be P. acnes or C. acnes, which is a critical indication. Now, this number for platelet-rich plasma, went over the numbers again. There's actually 12 studies, 2 randomized controlled trials, 5 prospective studies, and 5 retrospective, totaling actually just under 320 patients with 1 discitis case. So that this data is at an incidence is probably lower than this number initially was. And then for bone marrow contrite, there's also now a case study of 3 different discitis cases done by Dr. Lutz with bone marrow contrite. And this makes sense because if we look at bone marrow contrite, if we're putting a huge number of cells into that low nutrients, acidic environment, one, it can disrupt your microbiome, but also the huge release of cell death when all those cells die because they're in the desert, release a huge inflammatory response. So you can get an aseptic discitis as well. So it's why bone marrow contrite tends to be a little bit more of a risk stratification than PRP. And now we know PRP actually has a better functional outcome in pain and function, looking at some of our recent studies, level 1, level 2 studies. So this is one of the reasons why I, at this point, changed my practice where I only inject in the United States platelet-rich plasma into intervertebral discs. I really much don't see a need for bone marrow contrite based on the current studies and literature as well as the safety profile. So now, what are things that we can do to sort of minimize that risk when we're talking about, okay, how can we minimize that risk of discitis? We know it's a possibility. We know it's definitely a real possibility. And anybody that's had a patient with discitis, it's terrible. They get on antibiotics for 6+ weeks. They get a PICC line. Sometimes they even need decompression surgeries. So it's a big thing that needs to be talked about when you're discussing risk and benefits with your patients and consenting them for some of these interventional procedures. So if we look at some of the safety profile, and luckily there's been some studies out there showing, okay, what about different concentrations and formulations of platelets? Platelets with white blood cells, leukocyte rich, or platelets without white blood cells, leukocyte poor, as well as various concentrations. Looking at really the P. acnes control. So leukocyte-rich tends to be the more modifier, where leukocyte-rich can help. They have white blood cells. You have your neutrophils, your macrophages, so they can actually perform a defense mechanism, and they tend to be a little bit more superior in managing C. acnes overgrowth versus leukocyte-poor. So again, when I inject intervertebral disc, it's a very high concentration, usually around 20x, and I use a leukocyte-rich formulation. And now, what about, is there antibiotic that we can put in there that actually further minimizes that risk? And that would be a gentamicin. There's been, luckily these slides were donated to me by one of my colleagues, former fellows and now colleague, Dr. Maren Jerome, that actually showed, okay, gentamicin can dramatically reduce this. So this is a concentration mixture we're using currently, and we actually put that in our contrast when we do the disc injection. So it's a gentamicin mix. We take basically 10 milligrams per cc. We take one of those cc's, 10 milligrams, dilute that with 9 cc's of saline, take 1 cc of that, put that with 2 cc's of contrast, and that gives us our final concentration that really helps minimize your C. acnes overgrowth. So when optimizing, there's lots of things we can do. So anytime you're doing it, one, patient needs to be fully consented, understand the risk, the benefits of doing this, and making sure it's really indicated. So choosing the right PRP, making a high concentration of PRP, leukocyte-rich, as well as doing a full surgical prep. So you want it as sterile as possible field, and then utilizing a double needle technique. In addition to that, now we know I use 1 gram of Vanceft at the time IV, as well as intradiscal antibiotics, and that combination hopefully minimizes our chances of discitis. So overall, there's definitely huge benefit, and long-term wise, there's obviously more research that needs to be done, but the potential for PRP and orthobiologics in general, for one, helping annular tears, discogenic pain, chemical radiculopathies, it seems to be really beneficial and high, but it does come with risks. There's inherent risks that you need to discuss with your patients before you really go and do this. And then doing it, making sure you're well trained and minimizing the risks. Not every interventionalist is trained in doing intradiscal injections, as well as utilizing orthobiologics intradiscal. And now, this is one case where PRP is probably superior to bone marrow contra at this point. And so not every cellular treatment is better than PRP. And PRP isn't created equal. There's lots of formulations and combinations that you need to, if you're doing these injections, you need to be able to tailor make your injectate to what really the tissue needs, such as high concentration as well as leukocyte rich. Now, we offer an Interventional Orthopedic Fellowship. We're actually one of the only fellowships in the country. So any of you younger physicians out there that are thinking about doing a fellowship, young Dr. Gaddis will be our next fellow coming in January. But we're the only interventional treatment or interventional practice and probably the biggest orthopedic orthobiologics practice in the country, as well as probably the world. And we fully focus on sports and spine injuries, only utilizing orthobiologics. So we've cut out all of our traditional high-dose steroids, radiofrequency ablation, any of the traditional interventional pain management treatments. We sort of cut all those out, and we focus on how can we get patients better from a research standpoint. We're very involved in research, as well as training physicians on really how to do these type of injections adequately. And if you're already practicing and you don't know it, like I mentioned earlier, I sit on the board of Interventional Orthobiologics Foundation, which we run courses that actually have a regimented protocol as well as curriculum to really train you how to do these injections safely and ramp you up to simple injections to more more risky injections, such as an intradiscal injection from epidurals, facets, ligaments, and then eventually ramp you up to intradiscal, as well as other joints. We have very simple or advanced courses, simple meaning tendons, ligaments, simple injections, intra-articular, to more complex, such as ACL tears, rotator cuff tears, labral tears, and bone augmentation for arthritic conditions. So if you're interested in getting a little bit more better trained in how to do these, this is a list of some of the courses. In October 8th, I'll be flying out to Napa, training an intradiscal course at Dr. Bador's clinic, if you're familiar with him, out in Napa. And then this weekend, I'm actually going out to Portland, Oregon, training physicians on both shoulder, elbow, knee, and hip advanced injections, such as bone augmentation for, let's say, avascular necrosis, and more advanced injections like that. So I appreciate you guys for your time, and this has been really fun. Now I guess we'll open up the floor to any kind of questions.
Thanks, Dr. Markle. That was incredible. I'm going to start unmuting people. For those of you who are in your headset, I think you can try and unmute yourselves. Feel free to go ahead and ask us any questions. If not, I have a few questions myself. Let's see. Okay, I can ask. With these types of therapies, have you had any experience treating post-surgical patients or patients with like post-laminectomy syndrome or persistent spinal pain syndrome?
We have post-op patients, especially fusion patients, adjacent segment disease, typically blow out the disc above and below. One of the cervical intradiscal cases you see up there was a patient that had disc replacement, and we now know that adjacent segment disease is basically the same for disc replacements or fusions. So eventually got disc injury above the fusion, so we treated that with excellent results. But you have to be careful because once someone's had surgery, the risk of infection, other things, a little bit more higher risk. So sometimes starting a little bit more conservatively, let's say facets, epidurals, ligaments, more of that functional spine model, before you go to something more advanced like this would probably be more prudent.
I see. How frequently do you find yourself treating the disc with PRP in isolation versus, treating the whole functional spinal unit?
Never. I don't think I've ever just done just the disc. It's always done in conjunction with the functional spine unit. I feel like it, from a conceptual standpoint and capabilities with Ortho-Biologics, you have your best chance and best outcome treating that functional spine versus just going piece by piece because, okay, I get the disc, but the facets are already overloaded. We get rid of the disc pain. Eventually, you're going to have some facet arthropathy and facetogenic pain. Maybe in a young 20-year-old that had an isolated injury with a preserved disc height with a small annular tear and sitting intolerance is probably the only time that would probably make sense, but those are far and few between.
I see.
I have a question, Dr. Markle, to sort of build on Dr. Gaddis's question. When you approach overlapping pain syndromes, from degenerative spine disease in general, how has your treatment algorithm evolved to incorporate, discogenic treatment? I know there are many practitioners out there and physicians out there who sort of leave it towards the end. And I'm just curious to hear how it has evolved for you in terms of.
Yeah, it's definitely involved. And now that we have a good safety profile for it, such as intradiscal antibiotics, as well as our formulations with platelets, hopefully minimizing our chance of discitis. Now it's been a little bit, probably over the last year or two, it's been probably a little bit more aggressive sometimes, where we'll have that conversation if someone is more discogenic than anything, such as the sitting intolerance, and that's where the epicenter of most of their pain. Going intradiscal sooner rather than later sometimes makes more sense. But a lot of times we are more conservative if they've got a conglomerate of a lot of different things. Just staying extradiscal sometimes gets us a substantial amount of improvement without putting the patient at risk. So it's very much patient dependent. I would say in some patients we've been a little bit more aggressive over the last year or two, just because that safety profile now. But it's always more prudent, especially if you're just starting in the game, to be more conservative, staying outside the disc, and then if you need to, going into the disc. And I typically preface most of my patients like, hey, this has been going on for 20 plus years. You've had microdiscectomies, you've had surgeries, steroids, RFs, pretty degenerated spine. This may take a couple of treatments over the course of the next year. So usually I start with more of that conservative approach, and then we've already built in like, okay, maybe we need another treatment, see how she responds or he responds to this, and then make some decisions on how best to go from there.
Cool. Makes sense. Thank you.
Hey, Jason.
Yes.
Jason, John Kanab, that was an excellent presentation, man.
Hey, John, how you doing?
Good, good. Hey, do you think, do you see any reliably different changes in, motor type 1 changes in your end plates when you see the intradiscal injections? Are you looking for that, or have you noticed that even anecdotally?
I've noticed that in a few patients, some improvement, but it's not something I could really speak on consistently, and we haven't really got post-MRIs enough to really comment. But the few I have seen some improvement of the motor changes, but nothing to really write home about saying, oh yeah, this is something that improves left and right.
Right, reliably. Cool. The other question was, what was the final gent concentration you done? Is it was it 200 or 300, Mike?
No, it's actually 80 in the 80s.
Oh, so real low.
Yes. So this is so if you gave someone IV. Yep. So that's the dose you're basically, in the contrast, your dose is in that 300s, but by the time you're actually injecting it, it's far lower than that actually in the tissue itself.
Awesome.
Jason, can I mention something?
Yes.
I think that's your clinical protocol, right? That's not the concentration. That's not the concentration, John, from this study. The study was all in vitro. And it was, I don't know the dose in the study because we did it 3 years ago, but it was higher.
Yeah.
It was higher,
but I believe so.
But that high of a dose is detrimental to cells. And so I think collectively with Dr. C, we did some calculations and came up with this concentration to use clinically to combat the bacteria, but also to not do damage to the cells.
Thank you, Nevin.
You're welcome, John.
Thanks, Nevin.
Would you say that study was done in Virtuo or in vitro? I couldn't resist.
Nailed it.
So I have a question. When you are, when you have a new patient who is somewhat new to, orthobiologic therapies in general, and, you're explaining to them all the different contributions to why they're having pain, why they're, how their spine is degenerated, and you're telling them about this treatment, what can you, what's the story you tell them what to predict, basically? Like, do you tell, they expect to have pain, peri-procedurally for how long, what's that kind of time?
If it's extradiscal, I tell them it'll typically be a little stiff, a little sore for usually the first 3 to 5 days, and then see some fluctuations over the first 2 to 4 weeks, and ideally start seeing some improvement 6 to 12 weeks out. And then pair that with maybe physical therapy starting around the 2 to 4 week point. With intradiscal, it's a different story. It can definitely knock them on their butt for probably a good week or two. So we want to make sure they have a good environment. They're not traveling. They're have a good time off from work. No traveling. If they have kids, especially younger kids, it's like, hey, you may not be able to hold your child for probably a week, maybe 2 weeks. So making sure to prep them for the downtime that comes with an intradiscal, because having had intradiscal myself, it's a different beast. I've had PRP, extradiscal, it's no problem. I'm working out within a week or two. I got intradiscal. I was on the couch all weekend type of thing. So, and you can barely move. Like I said, the disc is 2/3 of your stability of your spine. So you blow that up with inflammation, any movement, it's very, very painful. Your body will compensate muscle spasms. You can get some radicular symptoms. So that conversation is far different than just saying extradiscal.
I see. Do you do any peri-procedural pain control medications wise?
After the post-op?
Yeah.
Yeah, usually I'll send them home with a muscle relaxer and maybe like tramadol or a low dose Percocet for the first day or two if needed. And I preface that I'm like, hey, this is insurance. If you need it, you have it. But usually a good heating pad, some Tylenol, and some rest will do them good.
Nice. I've been looking at these models over here. Would you feel comfortable kind of demonstrating to us just a general technique or, where you're injecting for extradiscal and intradiscal?
Yeah, well, extradiscal, if we look at this guy, there we go. So we're looking at this model. So if you're staying extradiscal, you usually do an epidural. So we can do an epidural right this way, called infraneural, and that gives us a probably good close proximity to the disc itself. Or you can go traditional supraneural. If you do a traditional interlaminar, the problem with that, there's very little spread anteriorly around the disc. So usually anytime we're doing any kind of epidurals, we're trying to get it as close proximity to the tissue target we want. So here we'll do an epidural transforaminal, usually infraneural or supraneural, sometimes even both. And from a disc standpoint, I'll usually bracket the disc. I'll come both sides. Let's say if there's an L5S1, I'll do a bilateral S1 and an L5S1.
Mm-hmm. Oh, sorry.
Sorry about that. Yeah, so I'll usually do, a epidural above and below, or at the level of the disc and below, because when you do epidurals, epidural spread always goes superiorly, just the flow of the epidural space. Rarely ever just goes below. So I'll try to bracket the disc and basically saturate that disc epidurally as much as we can, in addition to treating the supraspinous, interspinous, the intertransverse sometimes, depending on your anatomy, if you have scoliosis, and then multifidus that have some atrophy, as well as the overloaded facet joints. So it's all something like that we go through, like our IOF courses, that we train physicians on sort of how to do these different approaches. So a lot of people, if they want additional skills for sort of biologics in the spine, that's something I highly recommend.
Oh, okay. Very cool. Thank you. Again, the floor is open for those of you who are in here and have any questions. If you want to raise your hand or clap or make some noise, we can get you a microphone.
But it was definitely well attended.
Yeah, yeah. I think we had a record attendance today.
I think we did.
I think at the most we had 38. That's pretty good.
In the meantime, thank you once again, Dr. Markle. That was honestly such a fantastic presentation. I know I learned a ton, and I have a whole lot to dive deeper into. So thank you for that.
Yeah, no worries. Thanks for having me, guys. This is fun. My first
Do you mind if we take the
metaverse?
Hopefully not the last. Do you mind if we take a metaverse selfie real quick?
Yeah.
Let's do it. Over here.
If everybody wants to come down to the stage, we can get our selfie here going on. All right. Let's see here. Oh, okay. On three. 1, 2, 3. Nice. Look at that.
Nice.
I love it.
Very cool. So again, for those of you that are still here or kind of joined in later, we are called InVirtuo, and it's run by myself, James Gaddis, and my colleague, Dr. Omar. And basically what we're trying to do is we are trying to build a community for medical education, for anybody who's in the health professions to feel free to come to this space and have open discussions, give talks, promote learning, things like that. We have a lot of ideas and cool projects coming up in the future, and we're excited to share all this with you guys. You can find us on LinkedIn. You can find us on Instagram, TikTok. What else we got? Linktree, all the fun ones. So
we have our new website at InVirtuo.io.
That's right, InVirtuo.io. It took me a little bit to get used to the IO part. But thank you, everybody. Feel free to hang around. We have like a gallery of models.